Welcome to everyone who is joining us today. We're going to talk about advanced structural heart disease, and we're going to do this by going through three different diseases: aortic stenosis, mitral regurgitation, and tricuspid regurgitation. We'll talk about our treatment options for each one of those diseases and how we work as a team. Dr. Aziz is one of our cardiac surgeons. I'm an interventional cardiologist. So Dr. Aziz does surgeries, and I do catheter-based procedures, so less invasive things. We work together, sometimes doing procedures together, other times doing procedures individually for patients, depending on what best suits their needs. So we're going to go through some of that today. And as Joyce said, try to get through all of this in about half an hour to leave plenty of time for your questions. So thank you all for joining us. So to jump right into things, our first case is a 71-year-old male who presents with shortness of breath and is found to have severe aortic valve stenosis. In a moment, we'll talk about exactly what severe aortic stenosis is, but this is a really common presentation. 71 years old is probably right around the average for a presentation with aortic stenosis, and shortness of breath is extremely common with this disease. There are currently no medical therapies for aortic stenosis that either prevent its progression or treat it once it's severe. The only options that are available are to replace the valve either surgically or with a transcatheter procedure that we'll talk about. I will also make a note here that we are participating in some clinical trials, including one of a medication to potentially prevent or reduce the progression of aortic stenosis. So every patient that comes to our structural heart disease clinic to be evaluated for any of these problems, we also look to see if they may be a candidate for any of our clinical trials, and if so, we present those options to them as well. So this is the aortic valve. It is the exit from the heart to the rest of the body. So every time the heart squeezes, the aortic valve right here is pushed open. It should be very easy to push open, and then when the heart relaxes, that valve closes. In the kind of middle of the screen here, you see what the aortic valve looks like from the top when it's open, and then to the right of that is what the valve looks like when it's closed. Its function is to prevent blood from leaking back into the heart. But for reasons we do not understand, as people get older, they can develop thickening and calcification of the valve, and that's what you see in the middle of the screen on the bottom here. And that reduces the ability of those leaflets to move and makes it harder to push them open. It can also make it so the leaflets don't close all the way. I like to think of this as being like if you have a garden hose at home and you want to water the flowers on the other side of the yard, you put your thumb over the end of the garden hose, and the water shoots across the yard, and you can water the flowers. That's exactly what aortic stenosis is. It's like someone put their thumb over the valve and prevented it from opening. And hearts can compensate for this for a very long time. This develops over decades. But it eventually gets to the point where the heart just can't keep up anymore. It's kind of like running a marathon, and the heart eventually kind of runs out of gas. And when that happens, people get shortness of breath or chest discomfort, or sometimes can even pass out, because working muscles need more blood, and the body sends a signal to the heart to deliver that blood when you become active. And when the heart cannot deliver what the body needs, you develop that shortness of breath or the chest pain, or in an extreme, even pass out from that. So those are the things that those symptoms make us very keen to intervene on the aortic stenosis. If left untreated, aortic stenosis has a very high mortality rate. So in large population of patients, if we do nothing about severe aortic stenosis with symptoms, the mortality rate approaches 50% within a few years. So this is something we want to learn about when symptoms are very mild, or even identify this before patients have symptoms, and follow it closely, and then intervene as soon as symptoms develop. There's increasing evidence that we may even it may even make sense to intervene before patients have symptoms in order to get the best outcomes. So for this patient, part of our evaluation is to get a CT scan when we're deciding between the various ways to treat aortic stenosis. So this is an image from the CT scan, and what we see here, all this white on the image, is calcium. It's like a rock that has formed on this valve, and we can tell from this image that this patient is one of 2% of patients or so that have what's called a bicuspid aortic valve. They have only two parts to the valve rather than three. They've had fusion between these two parts. And those patients develop aortic stenosis at an earlier age. And therefore tend to require aortic valve replacement at an earlier age. And whether they have bicuspid or tricuspid valves plays a big role into what treatment options are available and what's best for them. So I'll let Dr. Aziz take over here and talk a little bit about the heart team and how we evaluate these patients in clinic to come up with the best treatment option for each one of them.
Thanks, Dr. Zarni. So the concept of heart team is really fundamental to providing effective and efficient care to our patients with diseases of the heart valves and coronary artery disease. So this concept has really matured over the past 2 decades and is now part and parcel of effective care. And well-working heart teams, time and again, have shown to have better outcomes than those institutions where the heart team is not well formed or not mature and don't work well together. Fortunately, at Hopkins, I can tell you that our heart team is phenomenal, and it's always a joy working with Dr. Zarni and my partners in cardiology and structural heart. And so it's a real joy to have this. So the bottom line is, with regard to heart team approach, we bring together team members from the different disciplines that are responsible for providing cares for our patients who are coming in to be evaluated for heart valve problems. That includes members from anesthesia, cardiac surgery, cardiology, imaging specialists in echo, electrophysiology, and even within the discipline of interventional cardiology, structural heart is further specialization given its complexity. And of course, our partners in industry, all combined to provide customized approach to patients. So the advantages of structural heart disease team are manifold. And just to highlight a few, number one, it allows us to ascertain all potential treatment options. And that is basically when a patient gets referred into the Hopkins Heart Valve Clinic, they are evaluated by both a interventional cardiologist, a structural heart specialist, along with a cardiac surgeon, so that we can evaluate a patient and be able to inform them of their options in terms of minimally invasive versus open sternotomy, and we'll talk about that, and to be able to evaluate the patients accordingly, and really, get from each one of us have certain areas that we pick up on, certain nuances of a patient's presentation, or how well they are a candidate for surgery versus minimally invasive or transcatheter options. And so all of those are really benefited by having a team approach. And then to determine best treatment options for each patient. And that goes, part and parcel of having an active collaboration and discussion. And we discuss all of our patients, both in clinic as well as a scheduled meeting once a week, where we discuss all the patients with valve pathology who are being presented for transcatheter options. And that is fundamental to our providing care for our patients. And it also allows us to plan procedural approach and detail contingencies, particularly as Dr. Zarni will mention later, transcatheter options are really, millimeters make a difference in having successful outcome. And you really need a very detailed plan for each patient. And that only comes with having experts sit in a room or in a meeting and really be able to analyze patients in detail and to plan for contingencies. And our procedures are done joint procedure performance of transcatheter aortic valve implantation and decision making is critical to having a very successful program, which we have at Hopkins, and the excellent outcomes that we've had so far is a manifestation of that. And ultimately, this allows you as the patient to benefit from a good, positive outcome and be home in a day, maybe in 2 days at the most, and has had a really phenomenal experience from the start to the finish. So this is really a fundamental to having a strong heart team, which we're fortunate to have. So in terms of this 71-year-old gentleman with, as you saw on the CT scan, having a bicuspid valve, a surgical option, if this person is referred for, let's say, after heart team discussion, the decision is made that they would benefit from a open surgical approach, then there are a few options and few items to think about. Number one will be the extent of the surgical approach, meaning sternotomy versus mini sternotomy versus a less invasive right anterior thoracotomy. All of these are surgical approaches that we can think about and counsel our patients. And then, of course, next thing beyond the surgical approach is the choice of the bioprosthesis versus mechanical prosthesis. So there are two main type of heart valve prostheses. One is made of tissue, either derived from cow or from pig heart lining, and those are incorporated and used in bioprosthetic or tissue-based valve replacements. And this picture here demonstrates that on the left side of the screen is the very heavily calcified bicuspid aortic valve. And you can see that this valve is not working well, and you can appreciate how dense this calcification is. And all of that leaflet tissue is excised, and in its place on the right side, you can see an aortic valve that has been implanted, and this is a tissue-based aortic valve, which has the advantage of not needing anticoagulation, but then there are obviously discussions about durability of and how long these valves can last. But this is an excellent pictures by one of my partners from an intraoperative picture, and that you can see how nicely and pliable the replaced valves leaflets look compared to the native. Now, the other valve, of course, in the aortic position is the mechanical valve, which at 71 we would be unusual to consider that. These are generally considered in much younger patients because they do require anticoagulation, but they have more durability. But this is the other big category of valve type that we would consider for an aortic valve replacement.
Great, thank you, Dr. Aziz. And I'll take over here with transcatheter aortic valve replacement. So again, when we evaluate patients in clinic with both a surgeon and an interventional cardiologist, we consider the surgical options that Dr. Aziz just detailed, whether that be a bioprosthetic valve, made of the lining of a pig or a cow heart, or a mechanical valve. And we can do TAVR or transcatheter aortic valve replacement with bioprosthetic valves. So these are either the lining of a cow heart or a pig heart sutured into a metal frame for these. It's a catheter-based, minimally invasive approach. So here you see this is open heart surgery, like Dr. Aziz does. This is the TAVR. So we make just a very small incision in the groin here. This is just a couple of millimeters. The tube goes in to the femoral artery, and through that tube, we are able to thread a catheter containing the new valve. The valve is crimped down. In most cases, this is only 5 or 6 millimeters in diameter. We thread that all the way up into the old aortic valve, and in this case, inflate a balloon to deploy the new valve, and in other cases, use a valve that actually opens itself up. We use the old valve to hold on to the new one. So whereas that calcium was what caused the problem, we make it part of the solution in doing a transcatheter aortic valve replacement. The benefits of the TAVR are that it doesn't require open heart surgery. We don't have to open the chest. We generally don't need to do cardiopulmonary bypass, where we stop the heart and take over the function of the heart and the lungs with a machine. And about 95% of these procedures, when we do TAVR, are done only with sedation. Patients they don't go all the way to sleep. They're comfortable and a little bit sleepy, but we can wake them up and talk to them if we need to. And they're breathing spontaneously the whole time. And this enables much quicker recovery. Most of our patients are walking 6 hours after the procedure, and a majority go home the following day. This is a much less invasive procedure, clearly, than open heart surgery. And again, shorter and easier recovery, and also a lower risk of most procedural complications. So in patients who are appropriate candidates, TAVR is really the most common procedure to do for aortic stenosis these days. These are the two valves we currently have available at Hopkins. On the left side of the screen here is the self-expanding valve. That's made of the lining of a pig heart. And on the right-hand side here is the balloon expandable valve. That is, the leaflets inside there are made of the lining of a cow heart. So even once we decide to do TAVR for a specific patient, which one of these valves we use depends very much on their anatomy and many other considerations. And so there's a lot of thought that goes into each valve replacement that we do. This is just a quick animation from Medtronic, which is one of the companies that makes one of these heart valves. You'll see here, we can go from, just going to pause this for a moment. We can enter through the femoral artery to put the valve in. That's the biggest artery most people have, close to the surface, so the easiest to get into and the safest. About 95% of our TAVRs are done through the femoral artery. If we need to, we can also get into the subclavian artery, but actually our second choice here is the carotid artery, because it's actually safer than going through the subclavian artery. When we go anywhere that is not the femoral artery, we put patients completely to sleep under general anesthesia for these procedures. Here you'll see the catheter goes in through the artery, is threaded all the way up through the aorta into the aortic valve. And then once it's in position, we just pull back this little plastic covering and the valve opens itself up. We do this with the heart beating the entire time. And again, the patient's sedated, but not asleep. And once we're finished here, the delivery catheter comes out and the procedure's finished. We close up the little hole we made in the artery, and patients go to our cardiology floor shortly after that. It's here. Good. So, before we move on to the next case, I'll just say, I think, that patient at 71 years old, if that's a patient who is a good candidate for surgery and doesn't have a lot of other severe medical problems, that's someone who could potentially get either a TAVR or a surgical aortic valve. And we would have a discussion with the patient, their family members, and Dr. Aziz and I all in the room to tell them the risks and the benefits of each possible approach here, and how we think this is best treated. And in many cases, the patient preference plays a huge role in that. We can go either way, and it really depends on their priorities. So we try to help patients think about their priorities in managing their valve disease, and then help them to come to a decision as to how to best treat it. So I want to be cognizant of time here. It looks like we're almost 25 minutes into this, so we've got two more diseases to go through. These will be a little bit quicker because we've already talked about the heart team approach, and we use that exact same approach for all of these diseases, and really anything that comes to our structural heart disease clinic. So this is a case of an 85-year-old woman who has high blood pressure and is found to have severe mitral regurgitation. What we see here is the normal mitral valve. So you'll see this is the aortic valve we just talked about. That's kind of the outdoor from the heart. And the indoor here is the mitral valve. It's supported by these, they're kind of like parachute cords. They're called the chordae, and these are the papillary muscles. And it's a very coordinated process every time the heart squeezes to tense this mitral valve and make sure that it doesn't let blood leak backward into the lungs. This is a picture of mitral valve prolapse, where this is the anterior leaflet. It has started to flop backwards into the left atrium back here, and that can cause a leaky mitral valve. You can also get a leaky mitral valve because the left ventricle, the main pumping chamber of the heart, is sick. It doesn't squeeze very well, it dilates, and that can cause the papillary muscles and the cords to kind of pull these leaflets apart, and that's called functional mitral regurgitation. Although they both result in a leaky mitral valve, they are two very different diseases, and they're treated very, very differently. So one of the first things we do when a patient sees us for mitral regurgitation is figure out why exactly do they have mitral regurgitation. Is it because one of these cords snapped and it caused them to have a flail leaflet, or is it because they've got a sick left ventricle and that's tugging on the valve and causing it to be leaky? The treatment for mitral valve prolapse or any primary mitral regurgitation is to fix the valve. The first treatment for functional mitral regurgitation is to treat the sick left ventricle with medications or various devices to help that to pump better. And many times, functional mitral regurgitation does not even need a direct treatment of the valve because it gets better when we treat the underlying cause. And this patient came in with shortness of breath while gardening, which is, again, a very, very common presentation of mitral regurgitation. So once we've decided why someone has mitral regurgitation and have decided that they need treatment for that mitral regurgitation more than just medical management, we go over the options. And I'll throw it back to Dr. Aziz here to just discuss the options for mitral valve surgery.
Thanks, Dr. Ghani. So briefly, when patients are referred for surgical correction of their mitral regurgitation, most commonly it's the posterior leaflet that tends to be involved more frequently than the anterior leaflet. And there are several well described techniques for correcting that. The one that is shown here in this diagram is a triangular resection, and the excess leaflet that is prolapsing is excised and is primarily repaired. It's a reduction, and then followed by a reduction annuloplasty. This is a ring that is placed to support the posterior leaflet or the posterior annulus, I'm sorry, of the mitral valve to help stabilize the annulus so it doesn't enlarge, and thereby correct the regurgitation. And then on the next is an alternative approach where those parachute cords that Dr. Zarni was talking about are artificially created with a PTFE, which is almost like a dental floss type of a material that is used to recreate those cords. And then again, a reduction annuloplasty is performed as is demonstrated on the right side. On the left, you can see the cords that are attached to the papillary muscle at the bottom right there, and then it comes through the leaflet of the valve itself and is tied down. And these two approaches have demonstrated excellent durability, and long-term outcomes have been fantastic with these approaches. But it does require an open surgical approach.
So when we think about the options for fixing mitral valves, as Dr. Aziz said here, surgery is it's really the gold standard, and it is the default when someone comes in with mitral regurgitation. And that's because the outcomes are excellent and they're very durable. Someone who has a flail posterior leaflet of the mitral valve and has a good surgical repair, they may not need anything else for the rest of their life. That can last them 30, 40, 50 years with no problems. The newer options that we have, the transcatheter options, have now been around for a while. This is the MitraClip here. This has been around for over a decade and has been shown to, in certain patients, be just as good as mitral valve surgery. And currently, that is mostly patients who are at high or prohibitive risk for mitral valve surgery. So this tends to be older patients with other medical problems that make surgery higher risk for them. With the MitraClip, what we do is we'll show a video of this in a second, but we put patients completely to sleep for this procedure. This is the MitraClip device. This tube goes in through a vein in the groin. We bring it up to the heart and we poke a little hole across the septum of the heart here. The clip is then advanced in, and we clip these leaflets together to bring them together and reduce the leaking. So if you look at the picture of the clip up here, the mitral valve leaflets would go in between these, what we call the grippers, and the clip arms. And then once the leaflets are in there, everything is closed to bring it together. So we'll show you, here we have a video of this. So here you see again the catheter going in through the femoral vein. That gets passed up to the heart. We perform what's called a transeptal puncture, which is just a little hole poked across the septum of the heart to let us get over to the mitral valve. Once that's there, we use a wire to direct our catheter into the left atrium. And once that's in, the clip delivery system is going to go in. So you'll see the clip come out here. We're going to flex that down to the valve. There's a lot of checking alignment here, making sure that everything is where it needs to be. And then the clip is inserted across the mitral valve that's leaking. We catch both the anterior and the posterior leaflet. The grippers secure things, and then the clip is closed. We can optimize if needed. And once we're happy with it, we're going to close all the way. We make sure that everything is exactly as we intended, that we've reduced the leaking of the valve, and then we will release the clip and take the delivery system out. We can put on one clip, we can put on two clips, we can do three clips even if needed. The big thing here is we don't want to make the valve too tight. So we tighten things up enough to prevent leaking, but not so tight that we affect the forward flow of blood. This is another option that we have. This is the Pascal device. It's very similar. This is just made by a different company. There are some anatomies for which this is a slightly better option, some anatomies for which the MitraClip is a better option, but we offer both of these devices at Hopkins. And in the last few minutes here, we want to discuss another disease that has largely been, frankly, ignored over the last 40 or 50 years, and recently has really been a lot. I think we paid a lot more attention to it, and by we I mean cardiologists in general. This is tricuspid regurgitation. So tricuspid regurgitation is pretty common. There are many causes of it. This is the tricuspid valve is on the right side of the heart, so it's performs the same function as the mitral valve, but on the other side of the heart. The reason that cardiologists thought we didn't really have to worry about the tricuspid valve is because there are congenital heart diseases that the tricuspid valve doesn't work, or treatments for congenital diseases that result in not having much of a tricuspid valve, and those people seem to do okay. But we've increasingly realized that this can be a big source of symptoms, things like shortness of breath and swelling of the legs, and that we can potentially treat this to help people feel better. So very common for patients to present with shortness of breath from their tricuspid regurgitation. And until only a few years ago, the only option we had for this was open heart surgery. And many times patients with tricuspid regurgitation have a lot of other medical problems that make surgery much higher risk for them. And so there has been a lot of reticence about doing surgery for tricuspid regurgitation in order to help people feel better. In the last few years, we have had the availability of transcatheter options for treating tricuspid regurgitation. So this is a commercially available option. We've been doing this for a few years at Hopkins now. This is called the TriClip. It's basically the equivalent of the MitraClip, but is used for the tricuspid valve, and it has some changes to the delivery system in that to allow us to work on the right side of the heart rather than the left. But it works exactly the same way. The tricuspid valve has three parts rather than two, like the mitral valve. So we clip together two of the leaflets. We can put on one or several clips, as many as we need to reduce the tricuspid regurgitation. With mitral regurgitation, we're usually always trying to get as close to completely eliminating mitral regurgitation as we can. In tricuspid regurgitation, these valves tend to be much more leaky, to have much more regurgitation. And so while we try to reduce that as much as we can, the clip tends to get tricuspid regurgitation reduced, but usually not gone. And in the last year or so, we have had the approval of a brand new valve for the tricuspid position. So this is a transcatheter tricuspid valve replacement. We did our first one at Hopkins just a few weeks ago, and um, with this system, we put a brand new valve into the tricuspid position. And so this, in most cases, nearly or completely eliminates tricuspid regurgitation. There are, as always, risks and benefits to everything. The downside of this transcatheter valve is a higher risk of needing a pacemaker after the procedure. And in addition, you need to be on blood thinner for some time after this. So that sometimes limits who can get a brand new tricuspid valve. So these are very exciting options that we are really in the early days of doing tricuspid valve interventions. And it's a really exciting field. Lots of developments on on an almost weekly basis. So the cardiology community in general has now paid a lot more attention to the tricuspid valve, and I think we're helping a lot of people to feel better through being able to treat their tricuspid regurgitation, whereas before that we just didn't really have anything good to offer. So I think that's about the end of our presentation here. Dr. Aziz, anything to add on tricuspid regurgitation or anything else that we talked about today?
Yeah, no, I agree. I think in interest of time, we'll keep it limited, but I think it's a real benefit to have these transcatheter options, because the surgical option, even though the surgery itself is relatively straightforward, the patient substrate by the time they come in for surgery is such that the perioperative outcome or mortality is much higher compared to other elective operations. And so the transcatheter option in the tricuspid space is very, very exciting.
Great. And with that, we will thank everyone for participating today. We are now, will transition to the question and answer segment of this. So if you have questions, again, please put them in the question and answer. Remember to send anonymously if you don't want your name attached. And we're happy to start taking questions. All right, so it looks like, great. So this is a great question. The question to us is, I recently heard that TAVR could be done through the neck. Can you please elaborate on this technique? So Dr. Aziz is what we're referring to here is a transcarotid TAVR. So going through the carotid artery, which is the artery in the, you have two of them, one on each side that brings blood to the brain. That is an option for patients who cannot get a TAVR through the artery in the groin, the femoral artery, because that is the safest way to do it, through the femoral artery, what we call a transfemoral TAVR. But if there's too much disease in the arteries, they're not big enough to get the valve up through the femoral arteries, then we consider transcarotid TAVR as our second option. And Dr. Aziz is actually the surgeon who does all of those with us, does the surgery to make a small incision to let us do that through the neck. And so I'll let Dr. Aziz elaborate a little more on what he does for that.
No, I completely agree. I think as you've mentioned, it's a small 3 to 4 centimeter incision that we make in the neck and expose the carotid artery. And it has, interestingly enough, not had any significant increase in risk of stroke, which is one of the things that one would have been concerned about opening up the carotid artery for access. However, in our experience and in the national experience, what we've all found is that carotid artery ends up being very safe because you avoid a lot of manipulation across a calcified aortic arch potentially. But in general, we've found it to be a very safe option for delivering as a second alternative access, basically the second alternative access of choice in these patients with really heavily diseased iliofemoral vessels. And these carotid artery cut downs, patients at the most are maybe stay an extra day. Certainly the first night we watch their blood pressure much more carefully to ensure that the incision and the site of access is healing well. And outside of that, after 24 hours, patients are back on their routine pathway.
Great. Thank you very much, Dr. Aziz. Looks like we've got a number of questions coming in here. So the next one is, are cow and pig tissues taken from processed livestock or grown specifically in a lab for these procedures? So I can take that one. So when these valves are produced, it's taken from cows and pigs, very specific actually. So each manufacturer has specific farms that they get their tissue from. It's taken from what's called the pericardium, so it's kind of the sac that surrounds the heart. Has to be a certain thickness. The tissue is all treated so that it's biologically inert, so your body doesn't reject the tissue or anything like that. And they're treated to prevent calcification, so to prevent the development of aortic stenosis down the line. And these valves are very meticulously made. So the two that we use, they're both hand sewn. I am told by the manufacturers that when someone trains to make these valves, that it's actually about 6 months of them sewing valves before a single valve that they have put a stitch in is ready to be used in a live patient. So it's a long training process, and that's just for the simplest stitches that they do. So these they take a long time to make. They're hand sewn, and it's really remarkable how these are made. Good. And then Dr. Aziz, maybe you want to take the next question, which is, can TAVR be used for a bicuspid valve?
Yeah, thanks, Dr. Donnie. Yes, so the short answer is yes. In fact, the experience with use of transcatheter valve implantation in bicuspid valve has grown tremendously, and in terms of outcomes, technically delivering the valve safely, number one. Number two, maintaining good contact with the annulus and having low paravalvular leak or leakage around the frame of the valve, as well as rate of pacemaker. We have seen really positive trends in all of those outcomes. And our experience with bicuspid aortic valve or transcatheter valve implantation in bicuspid valve has been fairly positive and is growing.
Great, thank you. Yeah, and I'll just add that, for bicuspid valves, so the devices that we use here are both approved for bicuspid valves and tricuspid. There are no kind of restrictions on that use. If it's someone who is, an intermediate or higher risk for surgery, then treating a bicuspid valve is usually not an issue. We can readily do TAVR for that. Some things that limit us, or if there's a really high burden of calcium, it can be hard to push all that calcium out of the way to do a TAVR, then sometimes surgery will be the better option. And many patients with bicuspid aortic stenosis are pretty young. And then we get into what to do about patients who are in their 50s or 60s with aortic stenosis. And really, all of the evidence for TAVR is in patients who are older. So even in the clinical trials of TAVR in patients at low risk for open heart surgery, the average age was about 72 years old. So we really don't have much data to guide the use of TAVR in patients who are in their 50s and 60s. So the guidelines for transcatheter aortic valve replacements are generally that TAVR is a consideration for patients 65 and older. We certainly do TAVR in patients younger than that in specific circumstances, particularly patients who are very high risk for surgery despite being pretty young. And the bicuspid morphology plays into our decision as to which to recommend, but we can definitely do TAVR for bicuspid aortic stenosis. Dr. Aziz, it looks like the next question is another good one for you since you do these. Would a mechanical valve be recommended for a patient in their mid-50s with aortic disease? Maybe you can talk a little bit about how you counsel patients regarding a mechanical versus a bioprosthetic valve.
Right. So thank you. Yes. So short answer is, after having conversation with the patients, my recommendation generally, assuming there are no specific circumstances that would be a contraindication, but in a healthy patient in their mid-50s, what we have seen from large registry data analysis of the STS national database is that patients in their 50s or anyone below 60 who underwent mechanical valve replacement compared to tissue tended to have a little bit longer overall survival. And of course, there are caveats to this, but in general, patients in their mid-50s do benefit from a mechanical valve because of several reasons. Number one, mechanical valves, once they are implanted and are functioning well, the gradient across them tends to stay stable for the duration of a person's life. They are very, very durable valves. That's number one. Number two is the risk of reoperation, reintervention is much lower with mechanical valve replacement. And so in my practice, I do tend to recommend patients who are coming in to have a mechanical valve. That being said, the one thing that has been a game changer for us, of course, is with the transcatheter valve implant, technology. We have now have the option in patients who are wanting to have a tissue valve to have a valve, a transcatheter valve be their second intervention if that is necessary. So some of it is changing and some of it is a little bit patient specific. But if someone were to ask for a general person who doesn't have any specific contraindication to anticoagulation, which is the main issue that we have to deal with mechanical valve, I think mechanical valve is a very, very good option.
All right, thank you, Dr. Aziz. The next question here is, how long would you expect a TAVR or operative repair for a bicuspid aortic stenosis to last in an otherwise healthy patient? I think the data are that bioprosthetic aortic valves, whether they be transcatheter valves or surgical valves, in general last about 10 to 15 years before they start to break down. Now, there are some surgical valves that were used previously that were subsequently found to have higher failure rates, and they can fail early. I've seen patients who have had valves fail after a few years, although that's pretty rare. And I've also had patients who have valves that are still functioning pretty well 20 years after they got them. So there's a broad range. We know more about surgical valves because they've been around for decades. TAVR has been around for the last 10 to 15 years. Many of the patients who got TAVR 10 to 15 years ago were very high risk and very sick for other reasons. And so a lot of those patients died before we got to see what their valves look like at 6 or 8 or 10 years. We are now starting to get more data about what these valves look like over longer periods of time. There's no sign that transcatheter valves break down sooner than surgical valves do. And there's a little bit of a signal that in some cases the transcatheter valve might last longer. But it's just too early to make any definitive conclusion about that. And we don't have any evidence, to the best of my knowledge, that it makes a big difference whether you're treating a bicuspid or a tricuspid valve. I think the larger impact on that is how good of a result we can get with the initial valve implants. So this goes a lot into our decision making as to whether to recommend a TAVR or a surgical aortic valve replacement. If it's an exceedingly calcified valve that we think is going to leave a compressed TAVR, it's not going to be fully expanded, there's going to be leaking around the valve, then that's someone who's going to do a whole lot better with a surgical aortic valve replacement to just cut those leaflets out and sew a new valve in there. But someone who we think we can get an equivalent result with surgery or a transcatheter valve, I would expect the durability of those valves to be about the same. Again, this is all for bioprosthetic valves. If someone is a good candidate for a mechanical valve, those tend to last longer, but and a lot longer. But the caveat there is they need blood thinners for the rest of your life. Let's see, next question is, what happens after the 10 to 15 year period of use is over? Which lasts longer, the self-expanding or the balloon? I will, Dr. Aziz, I'll have you address a little bit of this as well, but I will just start by saying that we don't have any evidence that the self-expanding or the balloon expanding transcatheter valves last longer, or that one of them lasts longer than the other one. The jury's still out on those. The transcatheter balloon expandable valve, the experience that we've had in the last several years, now we're starting to see some of these valves, they're old enough that they're starting to come back. So the balloon expandable valves our experience has been those tend to fail with recurrent stenosis. They don't open as well. Whereas the self-expanding valves tend to fail with aortic regurgitation, where they become leaky. We have not had many of these valves come back to this point. Most patients have these, that have had them for a decent amount of time. They're still working great. But this has now been around long enough that we have seen some people come back 8 or 10 years after their valve, and with signs that the valve is starting to break down. So what we do after that, and this is for bioprosthetic valves, for the surgical ones, we have a large experience actually putting a transcatheter valve inside of those valves. So that we call that a TAV in SAV. And we know a lot about doing that and the considerations, what we've got to watch out for, all of that. So for a lot of patients who have already had a surgical aortic valve replacement and need that valve replaced again, the default option tends to be a TAVR inside of that valve. For patients who have a TAVR and need something done, this is something that we're kind of in the early days of doing this, because we haven't had too many of those valves come back. And this is the case, not just at Hopkins, but across the country and the world. And so we're learning a lot about this. We have done some what we call TAV in TAV, where we put a transcatheter valve inside of a prior transcatheter valve with excellent results. But that's something that we're still learning about. So if someone comes to us with a failed transcatheter valve, we do the same process that we would for a failed surgical valve or even a native aortic stenosis, in that we get the CT scan that shows us a lot of the anatomy and helps us to decide what things are technically feasible to fix that valve. Dr. Aziz, any other thoughts on that topic?
Yeah, no, I think it's in essence that question is what a lot of our heart team discussion revolves around. So it's a very critical question, because we really want to be able to provide lifelong management of this aortic valve disease for a patient. And the first intervention really sets up what is going to happen or what the options will be 10 to 15 years down the line. And so I completely agree with everything that Dr. Zarni has said about that. And I think as the technology is evolving in this field, this question, the answer to this question is going to continue to evolve as well. But it's at the heart of basically it's at the heart of this management.
Thank you. Let's see. The next question here is, what are your success rates of TAVR at Hopkins? I can tell you it is exceedingly rare for us to not be able to complete a TAVR once we enter the room to do TAVR. And the chance of death during TAVR, during that hospitalization, is less than 1%. The rates of other complications, and this is the same in many places. This is a very refined procedure. So the general rates, and again, specific to the patient as well. So we try to tailor things as much as we can when we estimate a certain risk is higher or lower. But for TAVR, across kind of all comers, it's about a 5% chance of bleeding that needs a blood transfusion or damage to the artery that needs surgery to fix. There's about a 2% risk of stroke. There is about a 10% chance of needing a pacemaker after TAVR. This can go all the way up to 80 or 90% for patients who have pre-existing problems with the electrical system of the heart, and can go much lower than 10%, for instance, for a patient who already has a surgical valve that really protects the electrical system of the heart from the new valve. So we try to tailor our discussion of all of the options and the risks and benefits to each individual patient for each procedure. The next question is, what are the patient's options when they already have a mechanical aortic valve? Dr. Aziz, if you want to take that one.
Yeah, sure. So I think in that circumstance, I'm assuming you're asking if the mechanical valve starts to fail, what are the options? And in those cases, we try to see what the pathology is. If it's in the short setting, meaning if it's soon after, or if there was interruption of anticoagulation and patient may have developed blood clot that may have restricted the motion. In those cases, we try to deal with medication. However, over a long period of time, sometimes the valves can develop pannus underneath that can restrict the leaflet motion or just lead to higher gradients. In those cases, of course, currently we do not have a transcatheter option in the mitral mechanical valve. In that case, you have to do a reoperation and take it out.
Great, thank you. Just briefly here, it looks like, can you please talk more about BAV and TAVR for upper 60-year-old males? That question was probably written before we had a little more discussion about it, but I will just summarize by saying it very much depends on the individual patient and their evaluation. So when patients come to us for evaluation for aortic valve replacement, they see an interventional cardiologist and a cardiac surgeon. They get a coronary angiogram to look for blockages in the arteries of the heart, and they get a CT scan to look at their anatomy for TAVR. And so, as someone who's, say, 68 years old, who has very good anatomy for a TAVR, a calcified valve that's not too calcified, does not have any significant coronary artery disease, and has plenty of room in the aortic root for the TAVR, such that they may be a good candidate for a valve-in-valve procedure in the future, should this one fail. We would readily offer TAVR to that patient if that was their wish. At the same time, if that patient wanted surgery, I think that would be a very reasonable option as well. On the other hand, if it's a patient who has an exceedingly calcified valve and has blockages in all three arteries of the heart, but remains pretty active at 68 years old, that's someone we may strongly recommend surgery for, to get bypass surgery and replace the aortic valve, because we think that's going to give them the best potential for not having symptoms when they are through everything, and for doing the best in the long term. So it really very much depends on the individual patient. We are, I think, about 5 minutes from the end here, so it looks like I see 3 more questions here. I'll try to get through these pretty quickly. One is, how would you treat a 90-year-old female with overall good health that prevents with mitral valve prolapse and with calcium deposits in the aorta? I think that very much depends on symptoms. So a 90-year-old with mitral valve prolapse and severe mitral regurgitation, who is doing everything she wants to do, and does not have any shortness of breath or swelling in the legs, and is happy with life as it is, I would do nothing for that patient other than keep a close eye on it and tell them to call me if they develop symptoms. Once patients hit about 90 years old, for me, what we do very much depends on their quality of life. So something that we might be aggressive in treating without symptoms when you're 65 or 70 years old, that same disease in a 90-year-old, we may just say, we're not going to save your life by doing this procedure or fixing your mitral regurgitation. The only thing we're going to do is improve your symptoms. And if you're not having symptoms, then it's all risk and no reward. On the other hand, if that's a 90-year-old who is unable to do their usual activities, can't garden because they like doing that, but it makes them too short of breath, that's someone that I would offer, with appropriate anatomy, a transcatheter mitral valve repair, or if they weren't a good candidate for that, consideration of enrollment in one of our clinical trials for a new transcatheter mitral valve. So we're certainly willing to be aggressive in treating valve disease when necessary to improve quality of life, even in very elderly patients. But similarly, we are not aggressive when we don't need to be. So, again, someone who's asymptomatic, who is living the life they want to live, that's someone that I think we can medically manage at that age. Dr. Aziz, what is the convalescence time after surgical aortic valve replacement?
Right. So it's roughly about 4 days in the hospital, and after you get discharged after a routine aortic valve replacement, we have sternal precautions for about a month, meaning no heavy lifting, more than 15 to 20 pounds, and then no driving. And you got to really, avoid frontal trauma to the chest for about a month. During this time, by the time people come after a month to my clinic, they're walking over a mile. Usually their pain is minimal, and that's sort of 80% of the healing has been complete by that time. But overall, it takes about 3 months for patients to really feel back to themselves after aortic valve replacement.
Great, thank you, Dr. Aziz. It looks like we have time for one more question. So the last one here is, what percentage of patients end up having a stroke after TAVR? That's a great question, and frankly, I think that stroke after TAVR is what keeps Dr. Aziz and I up at night as well. It's one of those things that unfortunately there's just nothing we can do to prevent. So the overall rate of stroke after TAVR is about 2%. We know from studies of devices looking to prevent stroke that if we do an MRI on every single patient after TAVR, they have new areas in the brain that we can see, little clots or cholesterol plaque or something has gone to the brain. And this is in virtually every patient after TAVR. It's only about 2% of patients that causes significant symptoms that we would call a stroke. There have been trials of devices, most notably what's called the Sentinel device, which puts filters in 2 of the vessels and thereby protects 3 of the 4 vessels that take blood to the brain. But large studies of that device have actually shown no benefit in preventing stroke. The same number of people got a stroke whether they had the device in or whether they did not, which was really disappointing to the entire cardiology community. And the search continues. I will be very happy when we have a device that can help to prevent stroke after TAVR. For now, we are very careful about what we do. We do as few manipulations as we need to. And try to kind of get in, get out with as little as we need to do to minimize any chance that any debris causes a stroke. So with that, I think we will conclude. We're right at 6 o'clock here. Thank you to our entire audience for joining. I know Dr. Aziz and I could talk for another several hours about these diseases and what we do. This is what we love to do every single day. You will be able to access a recording of this. And please consider filling out the survey that you will receive that will help us to make these webinars better for patients in the future. So thank you all for taking time out of your day to be here with us. And Dr. Aziz, I will let you have the last word here.
No, thank you so much for taking time and joining us. And I'm so honored, and I'm glad that we were able to organize this and hear from experts like Dr. Zarni. It was a real pleasure to work with, and it's been a real good partnership.
And same here. Great to work with Dr. Aziz. I would trust any of my family members with him. So great to do this with him. Thank you all so much. And I think we'll end it there.
Thanks.